Thanks to Extempore for invitation. Today, I will talk about intracranial hemorrhage and local brain damage. First of all, we will speak about identification of blood supply and venous drainage by ultrasound. You can see here a blood supply of the brain in the anterior part in internal carotid artery. The second one, posterior part of the brain, supplied by basilar artery. And here you can see pericallosal artery, number 3, as part anterior and posterior cerebral artery. And venous drainage, you can see here superior sagittal sinus, straight sinus, transverse, and area of torcular herophyly. Again, superior sagittal sinus, straight sinus, transverse, and area of torcular herophyly. Here you can see medullary veins and superior sagittal sinus. Now we'll speak about normal circle of the Willis. Circle of the Willis composed by anterior cerebral artery, anterior communicated artery, middle cerebral artery, posterior communicated artery, and posterior cerebral artery. It's a very important part of the blood supply of the brain. I'd like to show you two unusual cases of vascular accident. The first case of destroyed corpus callosum during pregnancy because vascular accident. You can see here normal pericallosal artery, the subcallosal artery and medial callosal artery originating from the anterior communicated artery, supply rostrum, genome, and part of the body. The pericallosal artery, continuation of anterior cerebral artery, provides the main supply of the body of corpus callosum with its 4 main branches. Finally, this splenium is vascularized by posterior pericallosal artery and the distal branch of posterior cerebral artery. Anastomosis is present between pericallosal artery and posterior pericallosal artery. It's normal blood supply area of corpus callosum. In this case, you can see normal corpus callosum during regular anatomical scan in 23 weeks. And in 38 weeks, the patient referred to our center because suspicion to dysgenesis of corpus callosum. You can see here by transvaginal examination, just anterior part of the corpus callosum and corpus callosum destroyed. We can see just just anterior part, splenium was absent. And here you can see anterior part of the corpus callosum and a wrong course of the pericallosal artery. Something wrong was in the posterior part of the blood supply, posterior part of the corpus callosum. Vascular accident was in the posterior part of the blood supply of the corpus callosum. You can see here, splenium vascularized by posterior pericallosal artery, and this branch of posterior cerebral artery. Anastomose is present between pericallosal artery and posterior pericallosal artery. Something wrong was here. Vascular accident in the posterior part, and as a result, destroyed posterior part of the corpus callosum, vanishing corpus callosum. You can see here radial sulci coming until level of the corpus callosum. The second case of early bleeding into posterior fossa. The patient referred to my clinic for regular anatomical scan, early anatomical scan in 15 weeks of the pregnancy. And I saw mass in the posterior part of the brain, posterior fossa, and pressure of the hemispheres from the posterior part to the anterior part. During examination of the circle of the Willis, we can see here as possible cause of the bleeding, disruption of the circle of Willis. We can see here anterior cerebral artery, anterior communicated artery, middle cerebral artery, posterior communicated artery, and absent destroyed posterior cerebral artery. So it was vascular accident in the posterior part of the circle of Willis, and as a result, massive bleeding in the posterior fossa. The same case 1 week later, you can see increase in blood volume and much more pressure on the anterior part of the brain, on the hemispheres. So accident was in the circle of Willis. Massive bleeding in the posterior fossa, forebrain under severe pressure, and lateral ventricle, you can see here, and interhemispheric fissure. So case of massive bleeding in the posterior fossa. For comparison, you can see here mass in the posterior fossa, but it not was bleeding. It was tumor in the posterior part of the brain. You can see here vascular net, very rich vascular net of the tumor. Now we'll speak about prenatal sinus thrombosis. This condition can involve any of the brain venous sinuses, but almost all the prenatal diagnosis cases occur at the confluence of the superior sagittal sinus with transverse and straight sinus, the torcular aerophili. You can see here example of thrombosis of torcular aerophili on axial plane behind the cerebellum. You can see hyperechoic area of torcular aerophili. And by transvaginal examination of the sagittal plane, we can see here falx, vermis, cisterna magna, and torcular aerophili with thrombus. On the coronary plane, by TVS, falx, occipital horns, cisterna magna, and torcular with thrombus. Intracranial hemorrhage. Now we'll speak about intracranial hemorrhage. It's relatively common in preterm neonates. However, fetal intracranial hemorrhage is rare, with the estimated incidence approximately 1 in 10,000 pregnancies in the fetuses. In most cases, intracranial hemorrhage occurs late in pregnancy after a normal second trimester examination. The diagnosis is usually incidental during performance of routine third trimester ultrasound. Intracranial hemorrhage we can divide into 4 groups: intraventricular, subarachnoid, subdural, and cerebellar. Maternal factors have been associated with the fetal intracranial hemorrhage. Trauma, seizures, hypoxia, ITP, coagulation disorders, infection, febrile disease, medication, drugs, maternal vitamin K deficiency, and preeclampsia. You can see here example of the vitamin K deficiency. 30 weeks of the pregnancy, a woman was with Crohn's disease on parenteral nutrition. You can see here source of the bleeding in the basal ganglia, extracerebellar subdural hematoma, and severe anemia of the fetus. Again, bleeding in basal ganglia and extracerebral subdural hematoma. The fetal factors, bleeding may be because TTTS syndrome, maternal fetal transfusion, death of co-twin in monochorionic placentation, fetal thermophile, thrombosis of umbilical cord, cold entanglement, alloimmune thrombocytopenia, col4A1. However, in most cases, the etiology is unclear. Here we can see example of extracerebral subdural hematoma in 31 weeks of the pregnancy. Here, area of bleeding with subdural hematoma. We'll compare two different cases. In case number 1, we can see here blood around the brain, and in the case B, it's dural detachment. It's a relative common finding, absolutely benign. Two cases, two different cases. Subdural hematoma, common finding, absolutely benign, not confused with bleeding. Now we will speak about IVH. Classification of IVH: grade 1, bleeding confined to the subependymal area; grade 2, hemorrhage in the chorial plexus or lateral ventricle without dilatation; grade 3, ventriculomegaly; and grade 4, parenchymal involvement. Prognosis depended on the grade of the bleeding. Grade 1 and 2 comparable with the preterm neonates without bleeding. Grade 3 survival rates are about 95%. 2/3 of neonates have mild or severe neurologic sequelae. Grade 4 is associated with the most detrimental long-term neurodevelopment outcome, with only 15% of normal outcome mortality rate, is approximately 17% mild neurologic sequelae, 25%, and severe neurologic sequelae, 60%. Example of IVH grade 1, 26 weeks of the pregnancy, mild dilatation or not dilated lateral ventricle with hyperechogenic border of the lateral ventricle. 28 weeks, grade 2, hemorrhage in the chorial plexus, without dilatation of the lateral ventricles. "28 weeks of the pregnancy, IVH grade 2 and 3, with the clots in the lateral ventricles and lateral ventricle dilatations. grade 4, 33 weeks of the pregnancy. You can see here clots in the lateral ventricles and destroyed brain parenchyma. On the axial plane and on the coronary plane. One more case, 34 weeks, grade 4, bleeding with clots in the lateral ventricles with destroyed brain parenchyma. 38 weeks, grade 4, severe massive intracranial intraventricular bleeding. Periventricular infarction, hemorrhagic necrosis of periventricular white matter, large, mostly asymmetrical, often coexist with intraventricular hemorrhage. 15% of all intraventricular hemorrhage show periventricular infarction. I'd like to show 4 cases of the bleeding in general matrix with different courses. The first case, first pregnancy, 33.5 weeks pregnancy, follow-up for Blake's pouch cyst. MRI showed bleeding in the left caudothalamic groove, refers to our department for second opinion. On the transabdominal examination, we saw normal size of the lateral ventricles, normal cerebellum, and cisterna magna, not informative area of caudothalamic groove. By TVS, we saw normal corpus callosum, normal posterior compartment of the brain, vermis and brainstem, normal anterior complex, but something wrong was here with high echogenicity of the parenchyma. And this high echogenicity of brain parenchyma. This is image of mid-sagittal plane and source of the bleeding in the caudothalamic groove, 1 centimeter. But you can see here on the coronary plane, venous congestion and edema. You can see here a spread of medullary veins, and on the ultrasound, you can see spread of the medullary veins resemble medullary veins on the schema. High echogenicity in the brain parenchyma. In the scheme, you can see here distribution of deep medullary veins and high echogenicity resemble course of the medullary veins. Three weeks later, we saw areas of plaque accumulation here in the brain parenchyma. And similar findings we saw on the MR. Case 3, 22 weeks of the pregnancy. The bleeding started from the germinal matrix with damage of the parenchyma close to the lateral ventricles. We saw mild ventriculomegaly, blood clots, source of the bleeding in germinal matrix, and damage of brain parenchyma. One more case. We not saw parenchymal damage, but bleeding was started in the germinal matrix, close to the lateral ventricles, dilatation of lateral ventricles, but without parenchymal damage. And the last case, in 22 weeks, we saw bleeding in the germinal matrix and resolved in 25 weeks without dilatation of lateral ventricles and without brain damage of the brain. PHI pathology almost always associated with germinal matrix IVH, obstruction of flow in medullary veins by ipsilateral germinal matrix hemorrhage, germinal matrix hemorrhage, periventricular venous congestion, periventricular ischemia, and periventricular hemorrhagic infarction. Diagnosis by ultrasound. Lesion evolves into cystic formation, single and large, unlike PVL. Cyst rarely disappears. Major clinical correlate spastic hemiparesis or asymmetric quadriparesis. Mortality in acute period high for extensive lesions. You can see here timing of occurrence. Hyperacute from the start to 6 hours with hyperechogenic particle in CSF with a motion. Acute period 6 hours to 3 days. Hyperechogenic solid mass. Early subacute 3 to 10 days. Clot retraction. And the late subacute period from 10 to 21 days with hyperechogenic ependyma and cloth with gray center and white borders. Take-home message. Congenital anomalies are not always the result of abnormal embryogenesis, but can be the consequence of destructive processes. Not in all cases severe damage of the brain, we will see massive hemorrhage, but local destruction lead to the terrible consequences. Frequently, these lesions are not diagnosed in uterus due to late occurrence. IVH is the most common of all, and the ultrasound findings are dynamic. In some cases, it's very difficult to classify the lesion since within the end effect cavitation. Efforts must be made to identify possible cause of bleeding. Thank you.